From Faithful Word Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Hi everybody, Hashem Hasabala here. Welcome to Healthcare Musings, happy to have you. I am doing this episode in my special t-shirt, and I'm going to begin by having a shout out to pulmccm.org. It's a great Substack, pulmccm.org. It is written by physicians, clinicians who discuss the pulmonary critical care literature, break down the results, explain the statistics. It's a fantastic Substack. Everybody should subscribe to it. I'm a subscriber. I'm a founding member. And I have this really cool t-shirt that I wanted to show. They gave it to me. Here, let me move the microphone. So here, and that says in the back, I brought back PulmCCM 2024 right there. So it's really, really cool. I just wanted to do that. Sorry. Just a shout out. Definitely everybody should subscribe and support this their fantastic work. They had a recent post about palliative care in patients with advanced cancer, and I'm just going to be reading from excerpts from it. And it says in 2024, the American Society of Clinical Oncology published an evidence-based guideline update reaffirming its prior position that patients with advanced cancer should receive early palliative care because it leads to better outcomes. So as intensivists, we get patients with advanced cancer all the time in the ICU. They come in with septic shock, they come in with respiratory failure, they come in with pneumonia, they come in with collapsed lung, they come in with a whole host of severe illnesses, and they're very ill. Many of them are immunocompromised because of chemotherapy that they're getting, or radiation, or just the cancer itself. And so they're super sick. And so many times, there's been no goals of care discussion made about what they want when they suffer critical illness, when they are nearing the end of life. And so we as intensivists, and I'm not complaining, I'm very happy to have these conversations. And when I'm having the conversation with the patients and their family, it's too late. This really ideally should be done way before they see me in the intensive care unit. And so that's why the Substack highlights that the American Society of Clinical Oncology has an evidence-based guideline that's published that in 2024 that reaffirmed the fact that patients with advanced cancer should have early palliative care right in the beginning, to discuss, what their goals of care are, what kind of symptom management they are. And just to read further, it says that the ASCO guideline advises that patients with advanced cancer seen either in hospitals or clinics should receive dedicated palliative care as early as possible to proceed concurrently along with active treatment for their cancer. Referring to specialized palliative care early improves symptom management and increases the likelihood that a patient's goals of care and spiritual needs will be met. Concurrent palliative care should start promptly and no later than 8 weeks after the diagnosis of advanced cancer. And in parentheses, not as final hours transfer to hospice when death is imminent. And here's what they say, quote, do not wait to refer all patients with advanced cancer to an interdisciplinary palliative care team until the end of life, unquote. This was a strong recommendation based on moderate strength evidence. And the ASCO is the most influential U.S. Oncology Specialty Society. Its focus includes all cancer, but especially solid cancers. The American Society of Hematology, which deals with like hematologic malignancies like leukemia, lymphoma, they also have similar recommendations. And then they go over the data. There's really good data, really good published data that shows that early palliative care in advanced cancer improves quality of life and reduces symptom intensity. And in 2022, there was a meta-analysis of 12 randomized trials that showed this, and the effects were strongest when palliative care was initiated more than 3 months before death. What the travesty of this post is that here and is that when they survey oncologists, most don't do this. So let me just Read on. Few oncologists refer advanced cancer patients to palliative care early. In a surveyed sample cited by the ASCO, no oncologists did so. Zero. That is shocking to me. That's so shocking to me. 2/3 of responding oncologists, 68%, said they never referred their patients to palliative care at all, while 1/3, 32%, referred to hospice only in the expected last month of life. Now, palliative care referrals and integration of their services into cancer care are much more common at large, urban, highly resourced cancer centers. And it's true, there is a shortage of palliative care physicians and APPs. If I had it my way, every ICU that I would ever start or run would have a ready-to-go palliative care service integrated as part of the ICU program. They would round every day with us, and they would see patients. Everyone. I would screen everyone that comes into the ICU, and anybody that fulfills the screening criteria, they would have a palliative care consult. It doesn't matter if they're, again, 25 or 95. And the return on investment of having a palliative care program within the ICU that could, of course, expand to the hospital would be enormous, and it would pay for itself within less than 6 months, if not less than a year. That's if I had it, that's if I had it my way. And so why? I mean, that was shocking to me. Zero in this survey cited by the ASCO, zero oncologists. And so they're saying why. In another survey, oncologists reported aversion or skepticism toward palliative care, but 1/3 of them said they would consider referring it if it were termed supportive care, quote unquote supportive care. And so there are palliative care programs that are rebranding. I guess when you think of palliative, like if you're giving palliative chemotherapy, that means that there's no hope for survival. You're just trying to help. But that's not what palliative care is. Palliative care is a comprehensive program ascertaining goals of care, symptom management. What do you want to do? I mean, it's not just making people comfortable at the end of life. I think someone with a chronic illness that keeps getting admitted to the hospital should be seen by a palliative care physician or APP. I think there's a fundamental disconnect between what palliative care is and what many clinicians, especially many oncologists, think that palliative care is. And this is really a travesty, and it's really doing a huge disservice to our patients. And they mention a qualitative analysis of 23 studies of thousands of oncologists' attitude worldwide found themes of distrust of palliative care practitioners' competency, a preference by oncologists to control care, excessive burdens created by incorporating palliative care referrals into a practice, and concerns that care would be terminated early against the oncologist's advice. Again, the patient is ultimately in charge here. So, of course, the oncologist is fighting tooth and nail this cancer to try to give the patient as long and as quality of life as possible. And at the same time, sometimes the patient, we have to ask the patient what they want, right? When I have a patient that comes into my office as a pulmonologist with a lung nodule, especially if they're elderly or if they have maybe multiple comorbidities, I ask them, okay, if this nodule that you have if it's cancer, let's assume it's cancer, do you want surgery? Do you want radiation therapy? Do you want chemotherapy? If the answer is no, I say, have a nice day. There's nothing further to do. There's no reason to do a diagnostic workup. We have to ask patients what their goals of care are. As an intensivist, it frequently falls to us. I wish we would be given palliative care credentials, or maybe, and I've looked and tried to see if there's a coursework or some kind of credential, because we do it all the time. We do goals of care conversations all the time. I love doing them. It's part of I feel it's unfortunately part of my job, and it's part of the wonderful service that I can provide patients and their families by mitigating their suffering at the end of life. At the same time, really, it should not fall to an intensivist to do this kind of thing. It should not. It's too late when the intensivists start talking about, like, what are we doing here, right? And still, I'm honored to be able to provide that relief to my patients, especially if this is going to be the end of their life. And just to end, so this is really sad, and I think we should really try, and this is what I'm doing this podcast episode, really try to change this dynamic, change the thinking, and I hope more and more patients with advanced cancer get to see a palliative care physician or APP early on. And it shouldn't just be advanced cancer. It should be anyone with cancer or anyone with advanced illness. They really should be seeing palliative care. And I wish there were more palliative care clinicians across the country. And let me end with this. My eldest daughter passed away almost 16 years ago from cancer. She had diffuse large B-cell lymphoma. Unfortunately, she got septic shock and passed away June of 2009. It'll be 16 years this coming June. In the beginning of the chemotherapy regimen, I told her oncologist, I said, I know my daughter's sick. I know she can't breathe. I know she has a huge spleen, and that's impacting her ability to breathe. I know she has nodes everywhere. In fact, the cancer was everywhere when it was diagnosed. I said, I know all that. And she's happy. And my goal is quality of life. I want her to be happy. I don't want her to be miserable. And she said, I totally understand. And we embarked on the chemotherapy regimen, and it was brutal. Looking back now, she was miserable the whole time. Right? Does that mean I would not have done it? 100%. I would have done it again and again. I just know that the entire time she was absolutely miserable. And so when she finally was faced with critical illness, there was no way that I was going to prolong things or keep her on a ventilator or do anything like that. And thank God, I did not have to make that decision. The Lord made it for me. Still, I've had personal experience with this, and really, we have to change our thinking about palliative care. It's so important for our patients' wellness and well-being, and they have to know, and they have to ascertain, we have to ascertain, rather, what are their goals of care and what do they want. I can't stress how important it is. So thank you so much to the people at PullmanCCM.org. You should subscribe to the Substack. You should be a founding member like me. You'll get this awesome T-shirt, and they do fantastic work. And thanks to them for highlighting this and inspiring this podcast episode. Well, thanks so much for your time and attention, everyone. Until next time, Hashem Hasabala signing off on Healthcare Musings. Thank you for watching. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.